shout out. All right. Well, it is my pleasure to welcome our next speaker for building the antimicrobial stewardship team. I promise I can talk. Dr. Jaime Borkowski. She is an antimicrobial stewardship clinical pharmacy specialist at Northwestern Medicine Delnor Hospital. She completed her Doctor of Pharmacy at Butler University in Indianapolis and a PGY1 pharmacy practice residency at Northwestern Memorial Hospital in Chicago. She practiced as a clinical pharmacist at Northwestern Memorial Hospital following her residency, and then as the pharmacy clinical coordinator at OSF St. Anthony Medical Center in Rockford. Jaime then took a position at what is now Northwestern Medicine Delnor Hospital in 2009 and has spent the last 14 years building its antimicrobial stewardship program. She co-chairs the Antimicrobial Stewardship Committee and the Emergency Department Antimicrobial Stewardship Team at Delnor and works closely with practitioners to improve antimicrobial usage at Delnor and across the Northwestern medicine system. Jaime also precepts pharmacy residents and students in the areas of antimicrobial stewardship and infectious diseases. Jaime's primary research interest is in effective implementation of stewardship initiatives in the community hospital setting. She is an active member of the American College of Clinical Pharmacists, IDPRN network, the Society of Infectious Disease Pharmacists, and the Illinois Council of Health Systems Pharmacists. Thank you so much.
Thank you. Thank you very much for that introduction. And thank you all for joining me this afternoon to talk about how to build your antimicrobial stewardship team. Now, my colleague Radhika Polisetty is also helped me with this presentation. She is not here with me today, but this is a joint effort here. So when I say we, I mean Radhika and I. She works at Northwestern Medicine Central DuPage Hospital in Winfield, Illinois. So let's get started. Let's see. We have no conflicts of interest to disclose. And here are my objectives for this presentation. So those are there for your reference, but I'm not going to read through them in detail. We'll move on. So just to kind of a frame of reference, the Infectious Diseases Society of America and the Society for Healthcare Epidemiology of America released antimicrobial stewardship guidelines in 2016. This was an updated version, actually, but they kind of specify goals and objectives of an antimicrobial stewardship program. Sorry, if you can't hear me, just please like wave at me if I move away too far. So optimizing clinical outcomes through antimicrobial selection and dosing is one of those, as well as reducing unintended consequences of antimicrobial overuse, so drug toxicity, adverse drug reactions, emergence of resistance, C. difficile and other super infections, as well as increased healthcare costs. So that's kind of what we're trying to avoid when we have our antimicrobial stewardship programs. Now, before I talk about who we have on the team, I wanted to talk a little bit about team science and just team dynamics in general. I found this article that talked about collaboration with antimicrobial stewardship and infection control to create a team to address stewardship. And I thought that the concepts in here were really applicable to formation of the entire team. And I can see places where this would be useful even in our current stewardship team. So I thought I'd just talk about it briefly. I'm sorry if it's a little small to see, but so basically talking about team science, this is basically trying to leverage the experiences and expertise of different disciplines to bring them together. And originally this was really in the context of research, but it does apply to clinical practice as well. So when you look at the kind of the middle top of the slide, it talks about, first of all, leadership. So having an effective leader of the team is really the first step. It's someone who is going to be able to be a strong and effective leader, will initially help kind of determine the vision of the team and making sure that everybody on the team is kind of committed to any potential need for change that they might need to, have for themselves or for their colleagues if this is multidisciplinary, which is what we're hoping for. And then also, so readiness for change, as well as being committed to the team and to what this common goal is. So when you start with that, then we move over to trust, and that's the first one on your left if you're looking up there. And so trust is kind of established when everybody on the team understands that you are all working for the same common goal. So if someone is disagreeing with you or maybe has a different opinion than you, understanding that they're still coming at it from the perspective of trying to make the entire process better and not feeling attacked or feeling, like there's some sort of conflict going on. So when everybody has that kind of established trust as a team that we're all working towards the same goal, it really helps the team function more effectively. Then we come down to common understanding and open communication. So when you have different disciplines on a team, trying to get everybody to the same common language or understanding each other's professional language is one of those steps that you kind of have to take so that you can communicate with each other and make sure that you're all speaking on the same terms. And then open communication follows from that. So everybody can kind of understand and feel comfortable speaking their mind when there's some sort of issue that comes up. And then accountability is the next one up there. And accountability is really important so that the team actually functions, because it makes sure that things are happening. So people on the team need to have specific roles, and the roles need to be defined. So they need to understand what their role is. And then it's the leader's responsibility ultimately to hold them accountable to what those roles are so that things are happening the way that they're supposed to be to move everyone toward that direction. And finally, at the very top, effective conflict management. And I kind of refer to this a little bit, but once the team kind of gets together and starts talking about what things might have to happen, open really, really key so that you can have disagreement amongst each other within the team without excessive conflict. So people feeling comfortable that they can express disagreement and have the conversation and really have it be a constructive conversation where ultimately the best course of action is determined and then implemented. So that's kind of what I wanted to pull out of that. I thought it was really interesting. And then at the bottom section, there's stages of team integration, which kind of summarizes all of this. So you have the forming, the storming, the norming, and then performing. So it's all rhyming. I didn't make that up. But the forming is kind of when everybody starts, we're like, okay, we're going to do this, and this team is going to be so awesome. And everyone gets together and they're kind of excited. It's like the honeymoon phase. And then storming is when they all start feeling comfortable enough to disagree. And everybody's like, whoa, that's when people start having to kind of figure out how to effectively have conflicts. So disagreeing with each other without really feeling attacked, like making sure it's this open communication and being able to effectively disagree in the group. Then you get to norming. So people start to trust each other a little bit more. They feel like they're a part of the team. They feel accepted by the other members of the team. And once you kind of establish all that, you get to performing, where you really are able to work as a team to really work at a higher level of performance. So that's kind of, I'm just in reading those things, I really kind of felt like a lot of that was stuff that applied to where we're at in our team right now. So moving on, Joint Commission established the Medication Management Standard 09.01.01, which is establishing an Antimicrobial Stewardship Committee. They updated this in 2023, so this was effective as of January, these new elements of performance. So I just wanted to specify the ones that kind of address the stewardship team specifically. So element of performance 11 specifies the governing body appoints a physician and or pharmacist who is qualified through education, training, or experience in infectious diseases and or antimicrobial stewardship as the leader of the antibiotic stewardship program. So they specify a physician or a pharmacist who have ID and or stewardship, ideally, as the leaders of the program. Now, then there's also element of performance 13, which addresses the multidisciplinary team part of it. So they specify a multidisciplinary committee that oversees the stewardship program. So the hospital needs to have one of these, but they only have a note kind of specifying who might be considered. So they don't really specify who has to be on this team. They give lots of suggestions though. So physicians, pharmacy, nursing, infection prevention, micro, information technology, quality, etc. And they really also clarify here that it doesn't have to be someone who's full-time. It can be someone who's a consultant staff member, and they can be remote or they can be on site. So they really leave it open to what the specific needs are and the specific capabilities are of the individual sites to find the people that are really going to be the most effective members of their stewardship team. But they do give lots of recommendations on who might be useful people to consider, depending on who you have access to at your site. So I just want to get an idea here. So for those of you that do have an established stewardship team of some sort, how many of you have a physician involved? Great. And pharmacists? Excellent. How about nurses? So not as many nurses. Infection prevention? Very good. Micro? Good. Yeah, we struggle with getting micro involvement at my site. In fact, information technology or informatics of some sort. Awesome. Anyone have any others on their team that I didn't mention?
I'm housekeeping.
Housekeeping.
I'm a long-term care facility.
Okay.
So we involve every department head in our building.
Okay.
If you're on the safety committee, you're on the infection prevention.
Yeah, that makes sense. Anyone else have anybody that I didn't mention? All right, very good. So let's start talking about physicians. Now, ID physicians in particular, so the Joint Commission does say that it is helpful to have infectious diseases or stewardship training for the physician or pharmacist who are involved. But often ID physicians serve as the lead or the co-lead, or at least the medical director of the stewardship program. Now, IDSA and SHE strongly believe that ASPs are best led by infectious diseases physicians who have specific stewardship training. And there was an update to the CDC core elements in 2019 that does highlight the effectiveness of the physician pharmacist co-led team. And they did specify that almost 60% of hospitals reported some sort of physician pharmacist combination structure in that annual survey. So from my experience, I do have a physician, an ID physician that I work very closely with. He's the medical director of our infectious diseases and stewardship program at my small hospital. But so some of these are things that come from other places, and some of them are just from my personal experience where I really find him to be really helpful from a stewardship perspective. So first of all, some rules for ID physicians. They can provide guidance on the direction of the stewardship program. So maybe just kind of being aware of what issues are out there, what maybe they see in their patient care, with the, when they're getting consulted and issues that might have happened, et cetera. Leading stewardship initiatives, as well as helping in guideline and protocol development, overseeing that, as well as double checking it if it's something that I created myself. And the next one is one that I really feel strongly about. I think is very, very important, is serving as a role model for stewardship practices. I think that the ID physician, if they're going to be involved in the stewardship team, they really need to practice what they preach. It's really hard for us to say, oh, you need to do this, but then our ID doc, who's in the lead of our team, goes out and doesn't do that when it's the same situation. Really makes it hard for the other doctors to believe that you really know what you're talking about if your ID doc isn't doing that same thing. So that's, like, I think, very essential to have them be the first model of the stewardship practices. Providing advice on appropriate management of anti-infectives, so to pharmacists, to other physicians, of course, to consults and sidelines, but also collaborating with the stewardship pharmacists or other pharmacists on certain cases. So I also just kind of shoot them a message once in a while, say, I know this isn't your patient, but can you just take a look and see if you agree with me? Because I was thinking this, but I'm not positive. So they just kind of give me a little bit of backup in my day-to-day stewardship reviews. And then finally, serve as educators of other physicians, of nurses, and other practitioners in general. One thing that we're working on is actually kind of improving the knowledge of our general care practitioners at our site and trying to get them to be more aware of our protocols, our hospital protocols, because they're practitioners that generally work in the community but come in once in a while to see patients of theirs that are admitted. And so we tried lots of different things. We tried email education and other things, and eventually decided that it's going to be easiest for him to just directly talk to them when he sees a situation that is kind of what we were referring to. So when he sees them, like, hey, I noticed this patient had, you started antibiotics for UTI, but they didn't really have any symptoms. This is when we usually would just hold up, just trying to give them that real-time education instead of sending them a bunch of stuff in their email that they're probably not going to look at. Now, as Kyle mentioned, and anyone who had the opportunity to be at Kyle's presentation a minute ago about, I guess, in the last hour on communities, hospitals, and resource-limited settings. You don't always have the access to an ID doc, or maybe someone who maybe they're not on staff or they're not present. So what do? There's a lot of other physicians in the hospital, and many of them are super engaged and really would be awesome stewards and awesome champions for your stewardship team. And the first ones that come to mind are hospitalists. Hospitalists are kind of a natural next step. If you don't have an ID doc, they see a majority of the patients in the hospital. They drive inpatient prescribing practices at many sites. They coordinate care with the team. They talk to all the consultant physicians. They talk to the nurses. They talk to the family. And they also have a lot of opportunities for education because of all the different people they touch. So hospitalists are really key. And if you do have an ID physician who leads up your program, I highly recommend you have a hospitalist involved as well, because they can get that message out to a lot. It kind of spreads the reach of all the different people that they are able to touch. Now, there's many opportunities for hospitalists because they don't focus on just infectious diseases, but they touch a lot of other areas. And many of you are probably familiar with the Choosing Wisely campaign. And this isn't anything that's new, but it basically is from the American Board of Internal Medicine Foundation. And it's probably been about 10 years or so since they started doing this, but they basically try to identify best practices in many different areas of practice. They get experts who decide what are the most important things that the doctors need to know for their practice. And there's a few of these that really apply to stewardship, especially for hospitals, for example. So avoiding unnecessary invasive devices, so getting those Foleys out. Don't put the Foley in unless the patient really has an indication for it. Only test for infection when symptoms are present. I'm going to be referring to UTIs a ton because it's still the biggest problem that we have. And this is one of those perfect cases of patients that come in, they don't have any symptoms of a UTI, but they seem sick. So we're going to just treat them for UTI because their urine's always going to be positive because they're 80 years old and live in a facility. Sorry, I'm really getting editorial here, but it happens a lot. Discontinuing antibiotics after 72 hours if there's no evidence of infection. Next is avoiding antibiotics if the patient has recent C. difficile. And in my mind, if you can avoid antibiotics because they have recent C. diff, you might not have needed antibiotics in the first place, but especially if they have a history of C. diff recently, avoid antibiotics. Stopping surgical prophylaxis after the patient leaves the OR. This would be in collaboration with the surgeon, but the hospitalist is the next person the surgeon is going to talk to you about that patient's status, and the hospitals can prompt them and say, hey, do we need to continue these antibiotics? Because the recommendations are not to. So some places where hospitals can really help get involved directly as a member of the stewardship team, as well as just engaging them in your team. If they don't have time to be there for all your meetings, pull them in on these things, because it's really great to have a champion who can take these messages out to the rest of their peers. So syndrome-specific care plans, getting them involved in determining what the most appropriate diagnosis is, what the antibiotic selection should be for those different diagnoses, as well as an appropriate duration. When you engage them in developing these things, they're going to be way more likely to follow them when they're practicing on their patients because they know what went into developing them. And if you have a champion, they can also share that message with their team and say, hey, I know this seems weird, but there's data to support this. This is really what's recommended. We should really be implementing this on our patients. Discharge antibiotic timeout. So discharge antibiotics is really a huge area of opportunity. And so implementing some sort of a automatic timeout when a patient's leaving the hospital, having the hospitalist participate in just a critical review of antibiotics just at that point can make a huge difference in overall antibiotic use. So having them assess, do we even need to continue antibiotics? So how many days did the patient actually get in the hospital? And does that treat the infection they have? Do they really need 7 more days if they got 5 days of antibiotics on the inpatient side for a community-acquired pneumonia? Probably not if they're much better. If they're going home, they're probably fine without anything. And then also assessing target duration overall. So making sure that it's an appropriate duration, including what they got in the hospital. I'm always surprised at how many doctors really don't realize how many days the patient actually got in the hospital of antibiotics at the time of discharge. They aren't even sure how many days they actually got. Also, establishing criteria for an infectious diseases consult. Engaging the hospitalists in this will help increase awareness too of those situations where there are actually data to support improved patient outcomes when you have ID involvement. So Staph aureus bacteremia, for example, meningitis patients, fungemia. So kind of establishing those criteria. So when the hospitals see those patients, like, oh, we need to get ID pulled in here. And they already know about those things. And then finally, education of staff, of patients, and of family. They see these patients every day. Their families are there. They know their names. They're comfortable with those doctors. So when those doctors are telling them, you know, we didn't start your mom on antibiotics this time for positive urine culture because she didn't have any symptoms. And you should understand that when your mom gets, you know, confused, it's probably because she's not drinking enough water, not because she has a UTI. So giving that education, educating the family. So the next time the family presents, they're not like, oh, she always gets like this when she has a UTI, because they keep getting told that they have a UTI when it might be something entirely different. So really educating the family. This is a great place for the hospitals to get involved. Now, what other physicians really need to be pulled in? Surgeons. I would argue they're one of the most important groups to engage, and there's many reasons. So there's a few places where surgeons deal with antibiotics, so antibiotic surgical prophylaxis, and then empiric and definitive therapy of surgical site infections. Now, for surgical prophylaxis, up to 15% of all antibiotic use in the hospital is for surgical prophylaxis. It's a big percentage, so making sure that it's appropriate and it's the right drugs and the right durations is critical to helping your overall stewardship message at the hospital. So having the surgeons engaged in developing the guidelines and making sure they're appropriate, as well as looking at that duration post-op, just stopping it before they get out of the OR, will really help, again, get the surgeons engaged so that they will apply those when they're practicing on their patients. And that's really important. As far as empiric treatment of surgical site infections goes, this is a really difficult area, and the surgeons are key on this because source control is key, and the surgeons are the ones that know to what extent we have source control. So being able to work closely with them and having that dialogue with the surgeons is really important, because you need to be able to find out, you know, are you comfortable with the source control you got? What's going on with this patient? How much are we looking at here? Like how many days? Because if they got great source control, you might not need many more days, as opposed to a patient that you're worried about ongoing drainage, et cetera. And then you can also educate the surgeons on the antibiogram, so they're aware of how great our coverage is for E. coli, which is the most common bug that we might see in an intra-abdominal infection. So we know we could use cefazolin instead of ceftriaxone for those patients, et cetera. So having a surgeon on your team makes them more aware of all of those different things that they need to know to accurately treat their patients or appropriately treat their patients, and they can spread that word to their colleagues. Definitive management gets a little bit more difficult. Sometimes if we have a critically ill patient, they're a little bit more concerned about making some sort of, you know, more aggressive change. And then diagnostic uncertainty also hinders stewardship. So again, when you have a surgeon on your team, they can kind of give the surgeon's perspective on those things, and we can kind of help come up with protocols ahead of time to address these situations. Now, as you know, surgeons are usually pretty hesitant to change their practices. They are, if they've had success with the practice, you know, they're one of the areas where their results are publicly reported. If they have a surgical site infection, then their patients are going to know, and it affects patient care because, you know, they feel directly responsible for the outcomes of those patients in a special way because they were in there mucking around with whatever they were doing. But they also, it affects their, you know, their patient caseload because it's publicly reported. So having someone on the team who can help inform you and also share your message to them really helps kind of create a little bit of a bridge to the surgeons and decreases those barriers to getting the surgeons to actually do real stewardship on their patients. Now, this is an example, and I'm sorry if it's kind of hard to see, but I'll try to explain what these charts are. So this was a team that decided to implement a stewardship program specifically on a surgical unit in their hospital. And so they had a surgeon, they had physicians, a pharmacist, and a microbiologist on their team. And they were focusing on meropenem use specifically because they were seeing increases in resistance to meropenem because they were using it so much for empiric treatment of their surgical site infections in their surgical unit. So the chart on the left with the green was the meropenem resistance in their surgical department specifically. So they had kind of their baseline. You can see it trending up a little bit. So the top graph is Pseudomonas specifically. And then B is gram-negative bacilli. And you can see after that little arrow there where they started really focusing on trying to keep, you know, focus on using less meropenem for these. There was a decrease in the resistance they were seeing documented for their Pseudomonas and their gram-negative bacilli infections. However, the chart on the right down at the bottom, you can see that the trends for resistance for the chart A is Pseudomonas and chart B is gram-negative bacilli. We're still trending up as far as meropenem resistance for the rest of the hospital. So in the surgical units, they were kind of dropping, whereas the rest of the hospital still saw increased trends in their meropenem resistance. And interestingly, and this chart is not up here, but they did find there was one particular month where their meropenem use spiked back up, and they were like, oh, what happened here? So they went back and kind of did a review to find out what was going on in that month. And apparently that month, the surgeon who was on their team, who had been the one who was relaying the recommendations to the other surgeons, was gone that month. And so they kind of associated that increase in meropenem use with the absence of that surgeon who had been the liaison for the team and relaying these recommendations. So I think it does kind of hint at the importance of having a peer to kind of deliver that message and really make sure that then the physicians feel like they're being understood and that someone's talking to them who knows what they're dealing with. And finally, for physicians, I think emergency physicians are also key in engaging for stewardship. The emergency department is a little bit of its own beast, kind of like surgery in a way, but with different challenges, of course. So diagnostic uncertainty or lack of data, those things, that the emergency department's kind of, just kind of blindly trying to figure out what's happening in an efficient manner. So having the ED physician available to kind of help determine if there is a rationale to start antibiotics, and if there is, do they have to be started right now? Or do we need to kind of wait until we do other interventions or get some cultures or whatever? And then finally, using the rapid diagnostics available to them in an appropriate manner. So these are the first things. The focus on empirical therapy in the emergency department is also key. So one thing that's really important is that it impacts inpatient prescribing. So when patients were given the appropriate empiric therapy in the emergency department and they ended up getting admitted to the hospital, if they received the appropriate empiric therapy in the ED, then 83% of the time they received the appropriate empiric therapy when they were admitted. But if they got inappropriate empiric therapy in the emergency department, they had appropriate empiric therapy on the inpatient side 19% of the time. So it's like almost a 60% swing there. So it's really important for the emergency department to be engaged so that they know what the appropriate empiric guidelines are, get those things started so that if the patient does get admitted, that kind of translates into the inpatient side. And then similarly, and this is kind of very similar amongst all the physicians, of course, but getting their input when you're creating the clinical guidelines and the empiric guidelines really helps to make sure that they have that say, they can give their perspective. And then when you do roll those out, they feel more comfortable following them. They're more likely to really actually follow those guidelines and implement those practices. Getting appropriate cultures up front. And I argue this is a double-edged sword because sometimes in the emergency department, if they get cultures, because they're thinking, okay, we need to get everything that we need possibly so that when we start antibiotics, we can, know what we're treating later. But if there's a situation where they don't need to get a culture, and a result comes back later, UTI, UAs, urine cultures, then when the result comes back on the inpatient side and the doctors see that, they feel obligated to treat a lot of the time. So they might say, okay, the patient came in and they were confused, so they automatically checked a UA, it reflects to urine culture, but they didn't see it positive until 3 days, and the patient didn't receive any antibiotics because they were not symptomatic for UTI in that time. And then that third day comes and it's positive. A lot of times I look at this and I'm like, they didn't get anything for 3 days. Why are you starting antibiotics now? They're like, well, the culture's positive. I'm like, well, they were fine for 3 days. I'm like, you need to just document asymptomatic bacteria. So like making sure that they feel comfortable just documenting that is another whole situation. But if they had not checked that culture in the first place, they wouldn't be putting the inpatient physicians in that position. But on the other side, they need to make sure that they get all the appropriate cultures that are needed before they start the antibiotics so that we know what we're treating when we're trying to figure targeted therapy. So they really have to walk this fine line of making sure those diagnostics are appropriate and done in the right time. And then finally, most patients in the emergency department are discharged. So this kind of goes back to that discharge antibiotic problem. It is difficult, first of all, to follow up on patients sometimes. So they might get cultures in the ED, they go home, and then they have to kind of find those patients if the cultures are positive and follow up on how they're doing, et cetera. But discharge prescriptions are a really big opportunity, especially from the emergency department. So we do a lot with focusing on not sending patients out on antibiotics for upper respiratory tract infections. We try to really offer alternative treatments instead of antibiotics, so symptomatic treatments instead. So that's kind of where a lot of our emergency department work has been. But these are all opportunities for the ED, and having the physicians engaged in all these discussions really helps. So some other ideas as far as ways to really get the physicians engaged. First of all, when you're developing clinical decision support for physicians, getting the physician's input is key, because you really want to try to make sure that the decision support that comes up is useful, is efficient, and is not interruptive. So that it pops up at the time in their care of the patient where they need it, and that they can actually act on it. So getting their input really does help make the clinical decision support the most useful you can. Identifying a physician champion so that they can model stewardship practices in whatever discipline they're in, serve as a liaison to their peers, and then also help you identify really high impact areas or potential areas of intervention for the stewardship team. They can say, you know, our colleagues really ask a lot of questions about this. Can we try to address this, create a guideline, et cetera? Provide feedback to your physician team. So this is one of the only ways that it has been shown to change physician practice, is when you give them feedback and compare them to their peers. And Dr. Jeff Linder is actually here somewhere, and I think a lot of that work was his. He might not be in here. He's speaking in another session, I think. But so giving the physicians feedback, so individualized feedback on how they're doing on the target initiatives that you might be working on, and how their peers are doing, so they can see, you know, because it's the same group of patients. They can't say, oh, my patients are different. You know, when you're benchmarking against other places or just general, they always have some sort of reason why their patients are different. But if you're benchmarking them against their peers who are seeing the same population of patients, and you can say, okay, well, you're the best performer in your group, only prescribe antibiotics like 10% of the time or 5% of the time for this indication, but you're doing it 50% of the time. There's obviously room for improvement, and it helps them to really understand that you're not lying to them. You're telling them that there really is room for improvement. And then also highlight their successes. So make sure you give them the feedback on the initiatives you're working on. Show them how great they're doing. So one example, we have right now we're working on a UTI initiative in our system, and we're really trying to push to use cefazolin first line instead of ceftriaxone first line when the patient doesn't have any history of resistant organisms in their urinary tract. And so we just are sending out information right now about the flip that we've had in the system as far as the ceftriaxone curve going down and the cefazolin curve going up. And we want to share that with them to show that they really are making a difference. So we share that with the pharmacists who are intervening, and we're sharing it with the physicians who are also ordering them first line based on the guidelines that we shared. So making sure that they see that you care about what they're doing, that you're sharing it with the higher ups, and that it's important work. And then finally, one of the other things is the guidelines recommend like having prescribers do their own personal review. So a timeout, basically, you can call it what you want, but basically reviewing the need for antibiotics. So implementing strategies to encourage prescribers to perform routine review of antibiotic appropriateness on their own really helps the stewardship mission in general, because that's another set of eyes that they're thinking about it. So having things that are implemented to actually make them do that review independently of anyone calling them and saying, hey, I don't think this is right, or let's make this switch. Now, I do want to speak quickly about physician extenders, and I didn't really see much in the literature about physician extenders, so nurse practitioners and physician assistants, but we know that they also can be very effective members of your stewardship team. And I noticed that the VA actually established rules for implementation of stewardship programs amongst the VAs in the country, and they updated their guidance in, I think it was 2019. And in this guidance, they actually provide a framework that specifies the number of FTEs based on the complexity of the hospital, for how many physician, pharmacist, and physician extender FTEs they recommend or they require for different sizes of hospitals. And they actually do have up to half an FTE of PA or nurse, or advanced practice nurses time included in their stewardship plan. So there is a place for physician extenders, and I would argue they can perform very similar functions as the physicians, and having them, if they're involved in your physician team, then having them on your stewardship team will be as effective as having one of the physicians as well, because they can also share that message and help inform your decisions. And this document that I have in there does outline what that recommendation is, and I'll talk a little bit more about FTEs, but that's also a useful reference, and I'll talk about it. I'll talk about it in a minute. All right, so I'm going to move on to pharmacists, and similarly, pharmacists and ASPs. The core element used to be drug expertise, but they renamed it pharmacy expertise with this 2019 update to reflect the importance of pharmacy engagement for leading the implementation efforts on stewardship programs. Now, pharmacy expertise may not be an ID trained pharmacist, but they do recommend stewardship training for the pharmacists in whatever way that might be. And the pharmacist who is leading or co-leading the stewardship team can do prospective audit and feedback, help with protocol or guideline development. They can perform education for physicians, pharmacists, other like nursing staff, other hospital staff, as well as serve as a liaison to other committees for antimicrobial stewardship interests. So the sepsis committee, the surgical site infection committee, et cetera. But one thing I want to talk about, so the pharmacist who's leading your stewardship team does not have to be an ID pharmacist. I'm ID, like board certified in ID, but I didn't do a PGY2 residency in ID. I learned stewardship through my, PGY1 residency and just kind of doing it on the fly. And I did do a certification, but those things are not, I don't think that when they say formal ID training, I don't think I technically have any of that. But I will argue that extending the reach of your stewardship program can really be done by engaging your frontline pharmacists. And so not just having one of the frontline pharmacists lead up your stewardship program, but having them all be educated and aware of stewardship initiatives too, so they can actually implement it in their practice as well. So the pharmacists are well educated on the spectra, distribution, and dosing of various antibiotics. And if you give them targeted education, they're even more aware of it. And they also verify almost every order in the hospital for antibiotics. So they're touching all those orders. So I would argue that they are perfectly positioned to review the appropriateness of antibiotic orders at the time of the order, at the time the order was placed. And I think that this is the best place to intervene, because once you start Zosyn and the patient gets better, the doctor's like, oh no, they're getting better, I don't want to change it. But if the pharmacist says, hey, I don't know if they really need Zosyn for this, it looks like it's community acquired, can we just do cefazolin and flagyl? And they say, yeah, sure, and the patient gets better, then hey, win-win. If they don't get better, we have to escalate to Zosyn. Okay, but if we avoided days of Zosyn with cefazolin and flagyl, that's definitely a win. Additionally, the pharmacist can recommend appropriate lab values to either monitor therapy or determine if there's an infection present. So they can check procalcitonins, they can order MRSA screens. If they start vancomycin on a patient, they might check a serum creatinine or creatine kinase, et cetera. They can also follow up cultures and recommend either escalation if needed or de-escalation, as well as reviewing discharge antibiotics, again, for the appropriate dose, appropriate duration, and drug selection. So there's that discharge. It's really important. Now, this is an example of a process that we do at some of the sites in our system. So Radhika and I both do this, and some other sites also, I think. But this is a targeted antibiotic criteria review that we have implemented over the past 5 or so years. So we started out with fluoroquinolones, and we had such great success that we moved it over to Zosyn or piperacillin and tazobactam as well. But what we did was we established usage criteria where we had appropriate use of fluoroquinolones or pip/tazo, possibly appropriate use, and then inappropriate use. And so for every order of a fluoroquinolone or piperacillin and tazobactam that the pharmacist received, they would review the indication, because we do require indications when the physician orders antibiotics at our sites. They'd review the indication compared to our little descriptors that we gave them. And if it was either possibly appropriate or inappropriate, they'd contact the physician, have a conversation, and then if it seemed like it was still inappropriate, make a recommendation. And in our criteria, we also had alternative therapies for different types of infections so that they kind of knew what to recommend. And so we found, after doing this with fluoroquinolones, we started in fiscal year 16, so that's the blue line there. And as you can see, as we implemented it in the beginning, probably near the end of fiscal year 16, we had a quick drop because we were calling on all the fluoroquinolones. So I think ultimately the doctors just stopped ordering them because they didn't want to get a call about it. But I'm like, whatever works, if that's going to make them stop ordering them, if they know what the alternatives are, great. And we've actually sustained this drop in fluoroquinolone use. So our site's fluoroquinolone average is like 10 or less days of therapy a month right now at our site. And so we're like, oh, this worked great. Let's try this with piptazo. There's a lot more baseline required use of piptazo than fluoroquinolones, I would argue. So we didn't see quite a drastic switch, but we did see a significant drop in our days of therapy for piperacillin and tazobactam. This chart just shows a 2-year pre and then a 2-year post. So you can see they are separate a little bit, but we also got our standardized antibiotic administration ratio, or SAR, from the NHSN data down to 1 or below for the first time ever in our broad spectrum category after we implemented this process. So this is something that's still ongoing, and our pharmacists are still doing this. So there's a few, these are 3 examples of other papers out there that show either programs where pharmacists were doing stewardship practices, and also the one in the middle was actually just a process of how to build that pharmacist competency and educate them on stewardship practices. I thought these were all useful articles that might be good references if you're trying to figure out, the best way to go about educating your staff to involve them more in stewardship. So I know that most of you probably saw this morning because one of the speakers highlighted this, and I think it was, I forget her name, but she did an awesome presentation about, yeah, I'm totally blanking it now, but she did show this slide. But this was a survey, basically, that looked at sites that had stewardship programs, and they ended up evaluating, they got responses from over 250 sites. Mainly physicians responded, about 50 or so pharmacists responded. And what they did was they kind of assessed what their FTEs were for stewardship, what practices they did, so what kinds of things they did, and then what their outcomes were. And basically, they associated the FTEs with the effectiveness of the program. And so what they did was they published this recommendation based on the what was the most effective amount of FTEs per hospital site to show differences in their outcomes for stewardship. And the CDC core elements, they listed priority examples of for the leadership commitment specific recommendation. And 2 of those things were give AS leadership time to manage the program, and also provide resources, including staffing. And I think that having those 2 things in the core elements kind of back up the need for dedicated resources. And then this survey is actually referred to in the core elements, and they give actually specific recommendations for what should be, what your minimum stewardship resources should be based on your hospital size. So this might really be something that's useful to you if you're trying to get more stewardship resources for your site. You can refer to this. It's definitely not required. It's a starting point for a conversation at least. So say if your team, if they're like, no, we can't get a whole FTE, but you can say, well, a whole FTE is recommended, but we'll settle for 0.8. Then if they're saying great, then there you go. You got at least something. It's better than nothing for sure. So I thought this was a really useful survey. So check it out if you're looking to try to justify your resources. And then this is where I was saying the VA resources as well on that other slide with the physician extenders. They also have recommendations in there for FTEs of specific members of your team. So check that out as well. All right, so going into the other members of our team. Nurses. Now, nurses are, as you know, they are very central to patient care. They are very familiar with the patients and the families. They work with each of the doctors. They work with the lab. They work at the pharmacy. They are central, and they are doing a lot of the things and touching a lot of the things that really are affected by stewardship, or that affect stewardship, I guess I should say. So the American Nurses Association and the CDC got together and published a white paper for nursing involvement and stewardship. And this is like 2016, I think. And they identified a lot of the ways that nurses are already present and already there doing certain things, and kind of how they kind of highlighted what things the nurses can be doing to help with stewardship. So I highly recommend this paper. It's quite detailed. But some of the things we pulled out of there are attaining appropriate cultures in the appropriate manner prior to the starting of antibiotics. So the nurses have the antibiotic in her hand, she knows that cultures haven't been done yet, so she can just hold on to that antibiotic, get those cultures first, and then hang the antibiotic really quick. Use microbiology results to identify opportunities. So if the nurse is the first one to see that blood culture come back, she can, say, oh, the patient's not on antibiotics. We need to let the doctor know. And then helping identify infection early for timely start of antibiotics, for like example, for sepsis patients. And then conversely on this, I would also argue that the nurse is really key in not prompting the doctor when cultures maybe aren't necessary. So making sure your nurses are educated, or having a nurse on your team to help roll out this message, all your different stewardship messages. But the one that I find where nurses really, they do play such a key part in prompting the physician for the care of the patient. And this is in all settings. Hey doc, your patient is complaining of dysuria, let's get a UA. Totally appropriate. But hey doc, the patient's urine smells really bad, I think we should check a UA. Having the nurses be aware that that doesn't really count as a sign of infection if the patient's not complaining of other urinary tract symptoms might help prevent the attainment of a UA in a culture, and maybe prevent a patient from receiving antibiotics. Making sure your nurses are aware of those things can really help prevent unnecessary cultures. They can also prompt the doctor for de-escalation or for switches to oral. So if they see those cultures and it's susceptible to Bactrim and the patient's on cefepime IV, they can say, oh yeah, let's do it. I saw that it's susceptible to Bactrim. What do you think? I don't know if nurses are necessarily comfortable doing that though. So education helps. And then switching to oral. They're the ones that are aware that the patient's tolerating their diet and their diarrhea is gone. And so switching to oral is really a place. Finally, getting detailed allergy histories and documenting them appropriately. The nurses are there talking to the patient all the time, and they do a lot of the medication histories as well as the allergy histories in a lot of sites. So having them be aware of how to take a proper, especially penicillin allergy history, really helps when you're trying to figure out therapy for a patient. You're trying to avoid giving vancomycin when you can give, cephalexin or cefazolin. Now, this is a study that we published just a couple years ago, but we did this initiative where we were educating nurses on different stewardship practices that nurses could actually apply. And we did a survey before. So this is, Radhika implemented this at CDH, and she did a survey before she implemented the education and then after of the nurses. And one of the things that came out of this survey was the barriers to nurses' involvement in stewardship. And so one of the things was lack of education or expertise. So they just didn't feel like they didn't feel prepared, or like they could they didn't know enough about it to intervene. Time commitment. So nurses get pulled in a ton of directions. So having the time to do these things really is a problem for them. So maybe picking out one or two very specific things that the nurses can focus on might be helpful. Workflow issues is another thing that they mentioned. Perceived lack of authority. Oh, I'm just a nurse. I can't question the doctor. So not true, and we know that already, but a lot of them might not feel comfortable. And then finally, resistance from the providers that kind of goes along with the lack of authority. So these are all some of the barriers. So trying to overcome these is really helpful in getting the nurses more engaged in stewardship. So the white paper also has a little section where they recommend areas to kind of increase nurse training on some of these to help increase their ability to help with stewardship. So cultures, so obtaining and interpreting cultures properly, kind of looking at infection and determining the difference between infection versus colonization with blood cultures. This is interesting, assertiveness training. So really helping the nurse become more comfortable with opening a conversation with the doctor and having discussions about things that maybe they're afraid to bring up to the doctor. So helping them feel more comfortable doing that, recognizing when a patient's ready for oral switch. And then finally, allergy histories again. So lots of places where nurses are involved. Infection prevention, very, very integral in stewardship. We work very closely with infection prevention. So they play a vital role in tracking and containing infections in the hospital setting, including multi-drug resistant organisms. They are responsible for reporting several hospital-acquired infections to the Department of Health. They track surgical site infections and sit on those committees, and then also do a lot of educating of nurses and phlebotomists. And I would say that, sorry, I'm gonna get a drink here. So our infection preventionists, they're involved in many different things, and a lot of them are things that stewardship doesn't always get pulled into, or pharmacy for that matter. So they're really awesome at identifying when there's an issue where stewardship might need to be involved. So recently they were at a place where they were talking about increases in surgical site infections for a particular thing. And they're like, this seems like stewardship should come in here because I think there's an opportunity for some, stewardship interventions here as well. So they pulled me in and I thought that was really awesome. And then collaborations with infection prevention have been going on. My job was created because of our high incidence of C. diff 14 years ago at my hospital. And we worked very closely with infection prevention. So we implemented a stewardship program and then also all the things that go along with C. diff prevention, from hand hygiene and environmental cleaning, et cetera. So we worked very closely with infection prevention on that collaboration and to try to reduce C. diff. Microbiology. So I'm kind of running out of time, but this one is really important. So microbiology, there's a lot of areas where micro needs to be engaged. So we have diagnostic stewardship. So making sure that the appropriate labs are used in appropriate time, creation of antibiograms, keeping breakpoints up to date. So keeping it up to date with CLSI guidelines and making sure that the things that they're comparing the bugs to are really, really susceptible based on the most up-to-date guidelines. Implementing things like cascade reporting or suppression of different results, decision support, and then implementation of new technologies. So micro is very involved. And I did give a couple of examples here. So please review those. And these slides should be on your flash drive that you received. There's lots of great examples in this article of how how their lab implements stewardship things in their hospital and what kinds of reporting they do and stuff to prevent, to kind of help guide physicians to do the right thing and make it easy for them to do the right thing. So I'm going to just move on because I'm running out of time, so I'm sorry. But other members, information technology is super key. We really, really use them a lot to operationalize our alerts, to operationalize our guidelines, building interfaces for data submission to NHSN, and then also creating reports. So IT is super useful, and if you can get somebody on your team to help with this, it makes it so much more streamlined. And then finally, quality improvement in pharmacy learners, a couple of additional people that you might consider including in your team. So I'm out of time, but here's a summary, and I would like to open it up to any questions that you guys might have on anything that I talked about.
Are you seeing that the provider who's over your IT committee tends to be your AS provider?
Usually, yes. I would say, so the question was, is the provider who's over the stewardship committee also over infection prevention? I would say yes, that's generally what we see. I don't know, does anyone else have different experience with that? Do you have different providers over infection prevention and stewardship? Oh, yes, you do. You have different providers. Yeah, so in general, what I've seen is it's usually the same doctor. And when we had a switch in doctors, we did have the same one over both of them at our site, at least.
We're looking to write a policy for antibiotic timeout. Do you have any tools that you can use to get that?
So the core, actually the core elements and also the playbook, the antibiotic stewardship playbook, do refer to timeouts and might have some references in there that kind of specify the processes and maybe some literature to refer to for those. And I'm trying to remember if there's any other ones. Those are the two places I would start, though, the core elements and the playbook, the National Quality Foundation playbook. And Kyle referred to that in his presentation the last hour at the community and difficult, or sorry, resource limited settings. So the references in there for the National Quality Foundation playbook. Any other questions? All right, thank you all very much. I appreciate your attention. Have a great day.